All right, good evening from New York City. It's a beautiful spring day. Unfortunately, we're still dealing with the coronavirus. So let's just start. My first case is, okay, so he's a 57-year-old man and a practicing physician. He presented to my office with 2 weeks history of throat pain, and he believed that he could see a mass in the back of his throat and his left tonsil. Didn't have any other signs or symptoms. Specifically, did not feel any difficulty swallowing, voice changes, or anything else. Of note, he had a 50-pack year history of smoking. He had hypertension, hyperlipidemia. He had a DVT about 5 years ago, which was unprovoked. And about a year and a half before he comes to us, he had a major heart attack. He had an anterior wall MI, which sent him to cardiogenic shock. He had an intra-aortic balloon and had a left LAD stent, drug-eluting, and his current EF was 35%. He did have a ventricular thrombus, which he takes anticoagulation for. You can see that he's on Plavix, aspirin, Eliquis, and all the other suspects. On his exam, as you can see here, he had about a 2 or 3 centimeter exophytic mass in the left tonsil, which was limited to the tonsil fossa. There was no extension to the base of tongue and to the soft palate. As you can see, this is uvula here, this is the facial arch, and that's the top of the tumor. And this is the bottom of the tumor, just a spot right short of base of tongue here. He didn't have any neck masses, and the rest of his exam was basically normal. So, what would you do in these cases when you see a patient like that?
So, Bob, I guess no trismus or any difficulty with the exam itself?
A great question. No trismus and normal swallowing.
And you said, swallowing function was good, and the mass itself felt mobile, the palpation?
He did have some pain around it, but yeah, it didn't look like to be fixed.
And just so you guys know, some probably were on last week and some were not, but if you have questions or comments, please shoot them to the chat box, and we have folks monitoring that. Just it's a little easier just because we can't see all the participants as far as being able to call on people. So just introduce questions and thoughts based on that. So so typically in this context, we want to get imaging to assess for a few things, both related to the primary, you perform a complete exam, which you have done. I'm assuming you would do a fiber optic exam in the office. In the current era, you may suit yourself up a little bit more than you probably did at that time. And then that looks like it may be a tumor that could be amenable to a biopsy in the office. The question is whether it's going to cause an issue with bleeding given the anticoagulation, typically superficial ones. If you could cauterize them with silver nitrate, probably would not. But if you do, then obviously you would assess it for P16 at the time of the biopsy.
Yeah. All right. Perfect. Yeah, that's exactly what we did, and all great points. I like to do the biopsy right away in the office because they are there. And as Mike said, most of these, even when they are fully anticoagulated, if you're careful, you can get it done. So I did a transoral biopsy in the office. I use punch biopsies, and as Mike said, I usually try, if they don't stop, I cauterize it. Most of the time, you don't need to. The biopsy showed the keratinizing squamous cell carcinoma, and it was conventional rather than basaloid, moderately differentiated. And then we routinely now send for PD-P16 for all subsites. And also we have started sending for PD-L1, not specifically for P16 positive, but P16 negative definitely. This tumor, interestingly enough, turned out to be P16 negative and had a relatively high PDL score. And then I'm going to let Dr. Zahn, who gracefully accepted to join us again, to share the PET with you. Okay.
Hi everyone, this is Atim from radiology. Thanks for having me here. Let's see. All right. Here we go. So we did PET MRI on this case. Instead of doing separate MR and PET CT studies, this is a one-stop shop. And let me show you first of all how it looks. Can everybody see this colorful picture? You're looking at the entire body, brain, and the whole body, and the only positive PET lesion is in the left palatine tonsil at the neck, to start with. And there are these two tiny foci, which we will have a closer look in a second. So what do we see on PET? Left palatine tonsil, hypometabolic mass, 2.5 centimeters, confined to the tonsillar fossa. So the way we try to help you in terms of surgical, if surgery is on the table, the way we try to help you is to identify the lesions, the mass relationship to the pharyngeal constrictor muscles. You're looking at, this is conventional post-contrast T1, pre-contrast T1, post-contrast T1 coronal. They all have fat side, but unfortunately, we don't have enough resolution here. You are looking at the mylohyoid muscle, and this is the, I think this is anterior, this is the hyoglossus muscle, but you can't really tell what's going on here. So what we did is this high resolution sequence, again, it's less than 1 millimeter, 0.6 millimeter, KISS sequence. And the best way to see is the mass on the sequence. The dental artifact, please dismiss it, but this is what we mean when we talk about obscured evaluation of the oral cavity by dental artifact. So what you're looking at here, beautifully seen, is the pharyngeal constrictor muscle, this dark line, and the enhancing mass superficial to it. So we can confidently tell you here that the peripharyngeal space is clean, it's not violated, but on the other hand, we can confidently tell you that the mass is confined by the pharyngeal constrictor muscle. If you're planning on surgery, yeah, sure, go ahead. In terms of the lymph nodes, what we were looking at, these tiny, mildly FDG hypermetabolic lesions, lymph nodes, were this one and that one, these two level 2 lymph nodes. Despite their low activity, there's imaging features on KISS imaging, this one. The level of enhancement with mild central lack of enhancement itself are concerning for intranodal tiny necrosis. So we're looking at a left palatine tonsil, 2.5 centimeter, hypermetabolic mass confined to the tonsil fossa, no basal tongue, no glossotonsil sulcus extension, and it's definitely limited by the pharyngeal constrictor muscle with potential left level 2 metastatic lymphadenopathy.
Okay, great. Thank you. If you give me the screen back, to go back to my slides.
So, all right, how do I get
Just
back?
say stop sharing the top.
All right. Let me do this. Let me just sign out. I'll be back.
Okay. Okay, so we had our imaging, we had our biopsy. So basically T2 possible N1, N2B actually, because it's HPV negative, tonsil cancer. All right, what would you recommend and why? Any takers? Anybody would like to comment?
So one thing that maybe was mentioned and I didn't hear it, but the location of the carotid artery on the scan.
So fantastic point. I'm really glad that you brought this up. Whenever you think about these, when you look at the MRI and the CT, it's really important to pay attention to the location of the carotid artery, because sometimes our colleagues don't comment. So this was not a retropharyngeal carotid artery. It was away, was in the normal place.
Bob, I was wondering if you could comment as well on MRI versus contrast CT and why you chose MRI, and is that something you do routinely?
So no, we don't do it routinely. We still, majority of our imaging is done by CT and PET CT. We do have a protocol that when we do PET CT for head and neck, we do it with contrast. So we can use the same CT as our diagnostic CT. But in select cases, whenever there is question that a significant dental artifact, or there is a question about if the MRI is going to help us better determine surgery versus non-surgical and details, we do that. We do have a PET MRI machine at NYU, and Elchin is an expert. So we do a little bit more MRI than I would say other centers. We do also have a research protocol here for PET MRI. So that's the reason. But in majority of cases, I believe in experienced centers, PET CT would be adequate.
Yeah, the demonstration of the constrictor there with the fat behind it was impressive, and I could see where that could really make a difference in terms of resectability.
Yeah. I don't want to preach to everybody to get MRI. I completely understand that the cost is prohibitive and it's much more involved, but the technology is getting better and better. And sometimes I find myself that what I was taught 10 years ago might not apply today. Okay.
I think one of the other important questions is related to the nodes and whether you would consider an FNA of those nodes or just rule them in as positive based on the PET alone. It obviously is a big difference between stage 2 and stage 4 disease potentially, and what routes of treatment you might consider. And it's a lot of it, I think it's just dependent on the comfort level of you and the radiology team's discussion.
Yeah, absolutely. I think that's a great point. And I am one of those folks that usually emphasize on doing adequate and complete staging and make sure that we have it. Majority of time we do actually FNA those nodes, but in this particular case, I did not. He's on anticoagulation. You have to go back to Brooklyn and come back. And then the reason I didn't, because of, I'm just going to use Mike's comment as segues because we're going to finish. So if and you all know that, back, Kiana put this paper back in 2010 that there's a 25% difference between HPV positive and HPV negative. Granted, this is for stage 3-4, and we knew that HPV negative is worse outcome, especially because he did have a significant history of smoking. There was another factor that his cardiologist told us that he really cannot tolerate high dose cisplatin with his EF of 35%. And that was a huge concern for us. On the other hand, if you look at, there was a study that I did a few years ago, and we looked at the multimodality of earlier stage tonsil cancer. And we showed that this is an NCDB, this is retrospective data, and this is before the era of HPV, that you could see that people who had so-called early stage, if they had surgery plus radiation, they had much better survival than chemo RT or than radiation alone, or this other one is, or surgery alone. So surgery plus radiation on top, surgery alone, and chemo and RT alone. And based on, and specifically, if you look at tonsillectomy plus RT versus radiation alone, there's a significant difference here. And lastly, but before we do surgery, you want to think about the risk of surgery. This is a paper that just came out in Laryngoscope a few months ago. And one of our previous residents, Megan Turner, put with the folks from Stanford and Pittsburgh, that basically they looked at all the studies that done the risk of bleeding after transforal robotic surgery. And it's rare to have major bleed, but it does happen. It's about 6.5%. And 3% will have a major bleed. And the risk factors were prior radiation, post-operative anticoagulation, which is a very high risk, it's 2.25 increased risk. And interesting enough, the vessel ligation reduced the overall risk, but it wasn't significant. However, risk of major hemorrhage was significantly less. It didn't reach a statistical significance, as you can see. It's, the 95 confidence interval is still above 1, but it's very, very close. So looking at these, all these three, that this patient cannot tolerate high dose cisplatin, has HPV negative disease, has a potential for having advanced disease. We presented both, and what really shaped our thinking was we can't give high dose cisplatin if HPV negative is smoker, and we recommended surgery. And that's what the route we took. However, because of his significant anticoagulation, we did recommend to do a tracheostomy, which we never do for transforal robotics, especially for T2 tonsil. But in this case, we thought that if he has a bleed, and it's a major bleed, it's a significant, any hypoxia would be significant for his heart disease. So we went ahead with the transforaminal robotic tonsillectomy with a neck dissection. We put an elective tracheostomy. By the grace of God, he did okay. He had a non-complicated course. He restarted his anticoagulation right at day 3. He had no problem with the tolerating diet. He was in hospital for 10 days, mostly because he was a physician. He was decannulated on day 17. And this is his pathology report. His tonsil was a 3.2 centimeter tumor. It did have perineural invasion, had focal lymphovascular invasion. Our closest margin was the deep margin, but there was no tumor behind the constrictor with 1.5 millimeter, and we had 0 out of 27 node positive. So the teaching point, another one is, PET scan is very good, but it's not 100%. And what would you recommend in this situation, Mike and Arno? Would you recommend adjuvant treatment?
I mean, I think there are a few high-risk features: perineural invasion, lymphovascular invasion, even if it is focal, and there's a closed deep margin. On an HPV negative tumor, I would certainly lean towards considering adjuvant radiation therapy. I usually, as I'm sure most of the faculty on the call would go and actually look at the growth pattern of the deep margin as well. But if you're looking at things that would steer me towards considering radiation, those would be the factors.
Yeah, I would echo Mike's points on a classic HPV positive tumor. They tend to be very pushing. And in the absence of those high-risk features, 1.5, though close, I would consider negative. But for an HPV negative tumor with these observed kind of high-risk growth factors, I would at least refer him for radiation therapy and probably recommend it as well.
Yeah, I agree. And that's exactly what we did. And actually, we discussed this case again, and we discussed it with the patient who is a physician, and he elected for radiation alone. And we actually limited the radiation just the tonsil bed and the oropharynx, the most at-risk area, just to reduce the risk of hypothyroidism. They not need the entire neck. And he has done great, and he's back to normal diet. He's actually starting his practice back again, and his post-treatment PET is negative, and he's about five months out, and it's negative. So that's the case I had. The discussion point, as we discussed, HPV status is obviously the most important part. Perioperative anticoagulation has significantly increases the risk of major post-torch hemorrhage. PET scan is not always specific in identifying metastatic nodes. And also consider the toxicity of high-dose cisplatin. It's not a walk in the park, as they say. That's all I had. I'm happy to answer any question or have other presenters start their presentation. Thank you.
Excellent work, Babak. Thank you. And while we're switching over to Arno's case, are any of the other faculty on the line have any thoughts on the case that they would like to add?
Sorry, guys, I just joined. Yeah.
Oh, hey.
Look like you're in a post-game press conference. It's awesome.
I know Charlotte has a very fancy background.
We got to do it right, including my hoodie.
Well, welcome, Charlotte. Thanks for joining us.
No, thank you for inviting.
All right, can you
comment
see my screen?
Okay, go ahead. Yeah, I can see you.
Okay, perfect. So this is my case I'm presenting this evening. It's a 75-year-old man. This is actually a guy I treated back in 2015. So maybe, Mike, when you were here, about the time you were here, but 75-year-old guy presented to me with worsening left-sided throat pain and odynophagia. He had a history of a P16 positive. This was a T1N2A by AJCC 7 classification. So an HPV-associated squamous cell carcinoma of the left base of tongue. He'd been treated in the community. He had an upfront neck dissection, so kind of not classical treatment, upfront neck dissection for diagnosis, and then was treated with adjuvant/definitive chemoradiation to the primary and the neck, and had done well for 2 years. He had been eating well, full diet, good weight, minimal kind of but expected long-term side effects until he had developed these kind of sore throat and pain symptoms. He did have a history of coronary artery disease. He had had a CABG a couple of years prior to the surgery, but was otherwise active, asymptomatic, had a good cardiac function, good EF. He did have a history of tobacco use, 40-pack years, but had quit years ago and didn't have any really long-standing lung disease from that. This was his endoscopy. So it showed basically, and it had been, this was actually after biopsy, so there's some granulation there, but it basically showed an endophytic mass within the left base of tongue, kind of extending from the glossotonsillar sulcus just short of the midline. I guess we can pause there. Mike, thoughts, questions at this point?
Yeah, it's obviously a challenging situation, having had prior oropharyngeal surgery, neck surgery, and if I recall, you had radiation as well before. Is that right?
Correct. He had neck dissection followed by chemoradiation 2 years prior.
Yeah, and so, you know, in the context of this, you're not going to have a great non-surgical option for the patient. Obviously, with definitive chemoradiation therapy, that time frame would certainly put a very high risk for soft tissue necrosis and potentially even, you know, radiation necrosis of the larynx and potentially the mandible in the region, even though it's not directly overlapping it. But that said, looking at the primary tumor, just on physical exam, and I'm sure we'll see some imaging as well, you know, it does extend, it looked like it was past the midline down to get a margin. You know, you're already into the vallecula, it looks like, and so putting the larynx at risk as well. And somebody who's had that degree of surgery and chemoradiation therapy as well, even if you didn't have some of those factors, be at very high risk for chronic aspiration if the larynx was left intact.
Yeah.
I agree. These are very challenging. You see the difference between the last case and this case. This is really the edges of the tumors are not obvious, and that's very common after radiation and after prior surgery.
Yeah.
Added to the challenges, and also the interface of the tumor with the soft tissue is not exactly the same.
Yeah, good point. So we got a CT scan, kind of per our protocol. I just grabbed a couple images here to kind of demonstrate the tumor, but you can see this kind of ulcerative lesion with enhancing borders within the left base of tongue, kind of extending from the glossotonsillar sulcus. On imaging, it was actually less broad than it was on exam, on the endoscopy. And I think part of that was the endoscopy was after a biopsy had been performed, but does a pretty deep extension into, I think, past the lingual tonsil and into the muscle of the tongue. Here's another image further down as we head towards the vallecula. You can see how deep this fissure extends, and it's actually starting to get.
It seems like low volume tumor still.
Yeah, a relatively low volume tumor still, just deep ulcerative and endophytic. And then a couple images from the neck didn't demonstrate some atrophy on the left neck from his prior neck dissection and radiation, but there was no adenopathy in the left neck or in the contralateral neck as well. This was an outside PET scan, so I don't have the overlay images, but just in summary, it showed some activity at the base of the tongue, and it did not show any evidence of regional or distant disease.
What was the sequence between treatment and recurrence?
2 years.
2 years, okay.
And Arnaud, the hyoid bone and preepiglottic space, and I guess when you felt it in the OR, how did it feel with regards to the distal aspect of the tumor?
Yeah, so next, I took him to the OR for biopsy. He had already been biopsied by an outside ENT, hence the granulation at the site when I scoped him originally, but I took him back basically just for a diagnostic assessment to see, you know, given the kind of ambiguous margins that, you know, are difficult to appreciate on endoscopy, I wanted to assess it really for resection. And I actually could get a finger between the tumor and the hyoid bone. So I did feel like there was a margin of free mucosa between the hyoid and the edge of tumor. It appeared just short of midline. It did have this kind of deep crater where I could actually stick a finger into the ulcer of the tumor just off of the glossotonsillar sulcus. And the biopsy demonstrated still a P16 positive squamous cell carcinoma.
Rick, what would you do? You would take the patient to the OR in these situations too?
Yeah, I mean, I always do a staging endoscopy just to see how big this tumor is. The only one additional thing I do in base of tongue tumors is I get an MRI. I find it that it gives me better definition of the tumor in the CT scan. Because, a lot of time, and especially the sagittal cut on the MRIs can tell me how much of the root of the tongue is involved, and can have a conversation with the patient, whether they're going to have a total glossectomy or can we save any part of the tongue. And then also examine the hyoid, just like Andrew did, is to see if the hyoid is involved or not. Because if it's involved, then that I will not leave that larynx behind. I talk to them about a glossectomy, laryngectomy, and then go from there. But I always do endoscopy upfront before I commit a patient to a big operation.
Hi, this is Tamer from Henry Ford. How are you guys doing?
Hey,
Oh, hi, Tamer. How are you?
Good, good, good. Hey, question. So on the DL, how easy was he for exposure transorally?
He
Great
wasn't,
question.
yeah, he wasn't great. And the kind of deep endophytic nature of it made it really hard to visualize the entire tumor. Plus the kind of fibrosis and the stiffness from his prior neck surgery, I'd say it was a moderate to poor visualization on the endoscopy.
Yeah.
Yeah, sounds good. So that, that's one important aspect of taking to the OR, especially on these kind of things that are maybe difficult to tell the extent of disease and that kind of thing. It's helpful to do that DL to know how easy of exposure if you're contemplating doing a salvage with TORS.
Yeah.
So
Yeah.
I think that's helpful.
Okay, great.
So yeah, so I was interested here. I mean, I think there's different approaches that have been described, obviously, for salvage, particularly for P16, where people have advocated for minimally invasive approaches for these recurrent tumors. I pulled a couple kind of slides, and I'm just going to, in the interest of time, push ahead to this paper that was published by Magnuson in 2013, where they looked at kind of a case control series of, they looked at basically, there's multi-institutional series. They looked at historical matched controls of patients who had had salvage resections of primary recurrences of oropharyngeal tumors with an open approach versus a robotic approach. And they described this kind of really pretty dramatic results where the TORS patients had, despite the pretty well matched groups that you can see here, had really much better recurrence-free survival, had far lower incidence of tracheostomy, feeding tube dependence, and far lower perioperative morbidities, which, it wasn't controlled for HPV status. I think there's a historical bias in terms of the TORS patients were probably operated on more recently, probably had a higher incidence of HPV-related tumors. But I was interested to hear from you guys how aggressive you would be in terms of trying a robotic approach in terms of a salvage resection for HPV primary recurrences, though they're uncommon.
I think that's a great question. That's a perennial debate. I'll go first. I pick him very, very carefully. I think, as Shahrukh mentioned, you could go for it and you could have it, but you have to have a very good exposure, good tumor in the right patient, I would say. That would be my my criteria. Limited neck disease, local, that you have good access, you're not too worried about the exposure of too many vessels, and you can see their margins, you have a good sense of the margin. What makes me worried about this particular case, although it's a very small tumor, it's very infiltrative, as you said, and you really don't see the margins. And those are the ones that I'm worried that if we do, you're either going to get too big or too small and you get positive margins. So probably in your case, I would lean more toward having an open approach.
Well, for me, the important thing is how much does it come onto the carotid on your pre-operative imaging. So when I looked at your CT scan, it seemed like seemed to be plastered on the carotid right there on the base of the tongue. So when it's like that, I don't attempt a transoral approach. I'll just do an open approach to control the great vessels.
This is Don. I have to say, there's no question in my mind this would be an open approach, not transoral. I would do it transhyoid. There's no reason to split the mandible. And you'd open starting on his right side. you'd have vessels ready on the right for a small forearm, because you're not going to close that primarily after chemoradiation. And it's a safe surgery with minimal to no risk of bleeding afterwards, as opposed to a transoral approach with limited exposure. And I have to say that data, I mean, it's an interesting paper, but I think you have to interpret that very cautiously with regard to historical controls of who knows what. So that's my 2 cents.
Great point. Mike, you as a moderator, you get the last word.
Well, I don't know if my word's the right word. I would probably split the jaw for this. I would do it off to the side, just in front of the nerve to really maintain the anterior muscular attachments to try and minimize, the associated functional morbidity. There's no doubt it's more morbid. The proximity of that distal margin to the hyoid, I always worry about chasing little tumor strands down the muscle to the muscular attachment there. So I feel like, at least for me, would give me the best control of it. I do agree, fasciocutaneous flap would be the appropriate repair. I do think the, transhyoid pharyngotomy is a very reasonable approach. I just, my personal comfort level will be less with it, but it's not to say it's, I certainly, I know a lot of people have probably a greater comfort level with that than I do, so.
I agree.
So yeah, my bias is open approach as well. I haven't done a lot of salvage with TORS. It makes me nervous. I mean, we're so reliant on a negative margin in a salvage setting, and with the lack of palpation, with robotic surgery, I just get very anxious, particularly in the base of tongue. So I think I would, for a small tonsil recurrence, consider a TORS salvage procedure, but certainly anything in the tongue, I'm typically going to do an open approach. And I think that paper, presents it like TORS is kind of, comparable or better to open approaches and doesn't get that much to the nuance in a lot of these patients. It's really hard to do a negative resection. TORS.
Yeah, it's hard.
Salvage.
There's a question came out in the chat box. I think this is directed to Dr. Reed, his comment. It says, having not done any transhyoid, why would you recommend starting on the right side? Don?
Yeah, I was trying to type, but you saved me the agony. So very simple. This is not a lateral pharyngotomy. It's a transhyoid approach. So what you do with transhyoid is you separate the tongue base from the hyoid and you enter opposite the tumor. So you have visualization. So you enter and then you start making tumor cuts once you can see the tumor. So you always enter away from the tumor.
I see.
And because it's a tongue-based cancer, you're going to dissect the contralateral neck anyway. So you already have that exposure. So that's why you would enter, again, when I say the right, you're not entering the right lateral pharynx. You're entering at the vallecula as you would do for a laryngectomy, except far right, seeing the tumor, and then you make your cut up on the tongue piece from there.
Fantastic. Well, now that you said that, you have to treat us to one of your videos.
Yeah. Yeah, we do a lot of transhyoid. At least we did before TORS. And, actually it's an interesting point, because when you think about TORS and on your last case you were concerned about bleeding risk, you can do this case with a flap with really, you don't have your bleeding. So obviously you have a trach, so there is that. But anyway, it's just the historical comparison of open approaches. We all think about mandibulotomy, but that's not necessarily what you need to do. So morbidity is much less with this than mandibulotomy. It does take some practice, though.
So I'd like to add my 2 cents to this case. This is Tamer. I would, so I agree with Don. The transhyoid is actually nice. I would use that before doing mandible split. But with TORS, what I do is a combination of both. So I use TORS transorally to do the anterior portion of the tumor, do my tumor cuts, do my medial, lateral, sort of define all my cuts. And then the inferior cuts, depending on how well I can expose the patient, you know, and how well I can reach there. I don't do a transhyoid, and then, you know.
Tamer, you're going in and out.
I think we lost him.
Okay. All right. Let's, Mike.
Yeah, Dan, when you come back on, let us know. We can always let you finish that point maybe at the end of the next case. So Dr. Jalisi, if you present the third case.
Yeah.
Can we finish this case real quick?
Oh yeah. So
Okay, sorry, apologize.
No.
So I did a transoral approach, mandibulotomy approach. We did a forearm free flap. I actually got a pretty good margin. We had about a 5 millimeter margin around it. Luckily, no perineural, no PNI. A few nodes came out with it, and they were all negative. And he's actually done really well. He was trached and pegged afterwards. Took him about several weeks to get his trach out. And then he got his peg out about 3 months later and is now on a modified diet and doing well.
Fantastic. Excellent.
Andrew, how was the tumor along the carotid? Was it really scarred up?
It wasn't bad. It wasn't bad. Once we got up,
when people are going in to do these cases which have lost chemo, they've failed chemo RT, you got to be thinking about that carotid, because this thing can be plastered down on it. So if you're thinking about it, you'll get into disaster.
I think that we benefited from the fact that his neck dissection was done by one of the community otolaryngologists, where it was really just kind of a neck plucking, and so the deeper planes on the vessels were intact.
That's awesome. All
right. So now I need to stop share.
So I would say, if you want to summarize for all of our fellows, there are a couple of points. You know, just take these seriously. These are difficult cases. Be cautious with your imaging, with your staging. As you see, Arno was very, very comprehensive in his approach, and he did what he felt that would be the most comfortable for him to make sure that negative margin. The fact that this patient had negative margin is the most important thing. That's why he's alive. And obviously, you need good reconstruction, you need good everything to get these done.
Okay, should I share my screen, guys? Okay. Beginning. All right, can you guys see my screen?
Yeah.
All right.
Good.
Okay, so we're going to talk about a 64-year-old male who had a six-month history of a right neck mass. Otherwise, really had no other symptoms, just had this neck mass. He was seen by one of our community docs who had done 2 FNAs, which were non-diagnostic. And this whole workup took close to about 4 months, 4 or 5 months by the time he came to us, 1 FNA non-diagnostic, then they waited and got another one. Otherwise, pretty much just had hypertension. He was a non-smoker, non-drinker, and a good kind of guy. On exam, couldn't find any masses, but we did note a 6 centimeter right neck mass that was mobile. It was soft as well. And then the fiber optic exam was otherwise normal, vocal cords, and the rest of the exam on the fiber optic in the clinic was obviously normal. So any thoughts what we want to do right now? Any of the fellows? No?
So we haven't started, asking fellows. For now, they are just spectators.
Okay.
They're gonna vote to see who is their popular person.
All right, then I'll keep on moving. All right, so this is a summary. So he had a non-diagnostic FNAs times 2 on the outside. And the FNAs that were done on the outside were done by the otolaryngologist without any ultrasound guidance. So I wonder if that was, they didn't target it properly. But ultrasound guided FNA, in our office, we do use ultrasound. This was a cystic looking mass. He had metastatic squamous cell, P16 positive. I'm going to show you the CT scan of the neck. And that showed right neck level 2 necrotic lymphadenopathy. We do get an MRI, like I said, when I'm worried about something in the base of the tongue. I do like to get an MRI, and it showed a conglomerate of nodes in the neck. At this point, pretty much this was a unknown primary. Our exam, at least in clinic and by imaging, was not showing anything. So we went ahead and got a PET scan, which showed this thickening of the base of tongue, bilateral lymph nodes, and no distant metastases. So here's the CT scans. These two on the left are the CT scans. You can see there was some thickening of the base of the tongue / tonsil area. Here's this big cystic right neck mass, and I suspect the 2 FNAs he had without ultrasound guidance, they probably never got the capsule off it, probably got the necrotic debris. And then here's the MRI, and again, that's what they were talking about, thickening. Again, there's a lot of motion artifact over here, but there was something going on in the tonsils on the base of the tongue. So here's a PET scan, and again, the PET scan lit up in the base of the tongue, right in the glossotonsillar sulcus area, and you can see that the node itself really is not lighting up because, again, most of it is necrotic. Thoughts so far?
Dr. Jalisi, seeing that neck mass a little lower down, does that change your thought on the potential primary site? It seems
well, this is another aspect of it. It's really level 2 and 3. So that's where it is. If it's not level 4, but yes, if it's lower down, then you start thinking, is it nasopharynx or something like that, or thyroid? But with the P16, I think it's coming from the oropharynx. That's what you're thinking.
Right.
Yeah, I think, so first of all, Ashok, I really love your case because this is actually one of the most common presentations of P16 positive, HPV positive disease. You know, patients come in relatively healthy with just a growing neck mass that doesn't bother them too much, but it keeps growing, and you examine them and you don't see anything. Great job on getting the P16 on FNA, which we do also too, and you really don't need more than an FNA to get P16 status nowadays. I think you do see the primary tumor much better in the MRI. So I still don't have a very good view of where the tumor starts, where the tumor stops. If you are thinking about a primary surgical approach, which could be very reasonable in this case, I probably, before I offer him, I'd take him to the OR, do a DL, and look at everything and see if he's a good candidate for TORS.
Good. So remember the examination, the clinic really had shown nothing, you know, so all the stuff we had seen in on these imaging studies did not really correlate with what was going on in the physical exam. So we did take him to the operating room. He underwent bed endoscopy, and, you know, we did guided biopsies, which is essentially tonsillectomy. We did hypopharyngeal biopsies, nasopharynx biopsy. With these unknown primaries, we go ahead and do robotic bilateral lingual tonsillectomy at the get-go when we take them to the operating room. And this was done because in the DL, we didn't find anything. And there was no cancer in any specimen.
Wow.
So he's got pretty solid biopsies. The tonsils are gone, lingual tonsils are gone, and we staged him at the TXN1 because, you know, N1, as we know in P16 positive disease, is any multiple lymph nodes that are less than 6 centimeters. So that's why we called him N1 P16 positive. So thoughts? What are the options now?
So question from the group, Shahrukh, was the lingual, this is from chat box, the lingual and palatine tonsil, did you do it at the same time or you stage them? Because some people are worried about fibrosis.
Do them all at the same time.
Same time.
Yeah.
How are your
I don't see the fibrosis. I mean, we do come down. I do leave behind a little bit of mucosa right at the inferior pole of the tonsil, and then go ahead and take this out. But you know, I haven't seen that. I've read about it. I've heard about it. But I think when you do this, you can just pull it up and take it out, and I just take them out at the same time. Part of the reason is resource utilization. We don't have the luxury of just having a robot standing around, you know. So gotta do as much as I can.
Sure.
So what do you guys do next? I mean, so what are the options here? Dr. Bewley? Yeah. You're muted, Andrew. You're muted.
No, you're
muted.
I'm muted. Oh.
No, you're fine.
Oh, yeah.
You can't read my lips?
No.
You're not that talented.
When you do your tonsillectomy, do you just send everything for permanent, or do you sequentially excise the tonsils and serial section them as you go and look at them under frozen section?
No, I just send them out for permanent section. Just take them out and we wait.
And if you get a say a base of tongue cancer that comes back and they say it's positive margin somewhere, how do you address that?
So after the permanent, you just go back in, and if it's a small margin, then you'll talk to the patient. So let's say this lingual tonsillectomy we did had squamous cell in it, and there was an edge of it that was a tumor. A lot of it would depend what he wants to do with the neck. If he wants to go for primary chemoradiation, then we'll just leave it alone. Then it becomes a big biopsy, basically. Otherwise, if he says, hey, I want to continue on the surgical path, because we'll talk about the NCCN guidelines right after this, then we take him back and re-resect wherever it was. We do very careful labeling for them and orientation for the pathologist. Part of the problem we have is that we have only a couple of head and neck pathologists who may not be on there for the frozen sections on a given day, and then it becomes a logistical problem. Is someone's running across campus taking it over? So I just stopped doing that because it was taking up to 2 hours for those frozen sections to come back.
Yeah, I agree.
All right, so I think all of us have our own institutional resource problems, but we work with them. So here's the NCCN guidelines for occult primary neck mass. We did the FNA, it came back as squamous cell. Can you guys see my cursor, by the way?
Yes.
Okay. So, he got the imaging, primary was not found. We'll keep on going in the C workup and treatment section. This would be node in the upper third, basically, of the neck. And he got all of this stuff. Primary is still not found. He has squamous cell carcinoma. And then we look at the definitive treatment paradigm. So obviously, remember, this is P16 positive, so it's N1, and neck dissection is the preferred modality, or you can do radiation therapy. So I don't know how many of the fellows know this, because this was changed, I think, about 2 years ago, because prior to 2 years, you would be giving them chemoradiation, concurrent systemic that switched in the NCCN. So that's what I was talking about. Mike, I think you asked if there's a positive margin. I think it'll all depend on the patient's preference for the definitive treatment, what to do. So questions or comments at this point?
No? I think it's a very good point, and especially if there's a question on whether or not there's extracapsular spread in the nodal disease. Sometimes at the time of the endoscopy, you could even do the neck dissection to try and establish that. If a patient based on the neck disease alone is going to require chemoradiation therapy, which obviously that's a point of discussion in and of itself for HPV positive disease, but if a lot of institutions lean back on the prior, high level data that we have to support that as an indication for definitive or adjuvant chemoradiation therapy, that can then steer you on how aggressive you are on the primary. If they have a small primary and they're gonna require chemoradiation therapy based on neck disease alone, then certainly wouldn't put them through a lot of additional morbidity for throat surgery. But as we all realize up front, surgery a lot of times yields them better functional results, especially in the instance of being able to de-escalate the adjuvant therapy.
Yeah.
So we have a couple of questions from the fellows. There's asking about the bilateral tonsillectomy versus unilateral. Shahrukh, can you walk us through your thought process? Why bilateral?
So I do bilateral because when they get the post-treatment imaging scan, that one tonsil always sticks out, and then I got to do something about it down the road. It'll always light up, So I just don't want that kind of chest pain, so I just take it out. So I've done that pretty much all my career. You can do unilateral if you want to do that, but you better have a plan that when it does light up on that post-treatment PET scan or imaging, because remember, this guy's from the community, he's going to go back to the community, and some radiologists will say there's an asymmetric tonsil on that opposite side, right? I think all of us have dealt with it. So I just
oh my God.
So I just stopped that drama early on.
Share your feelings.
So I would say, I agree with Shahrukh exactly. I think tonsillectomy, we don't do a radical tonsillectomy on the other side, we just do a regular tonsillectomy. And, tonsillectomy is well tolerated. Lingual tonsillectomy is a different story. Yeah. And I personally, when I start on the left, the ipsilateral side, and I take the tonsil out and I take the lingual tonsil, and I wait If we are done and there's nothing there, I might take the other tonsil for the exact same reason that Shahrukh said. But I try not to do bilateral lingual tonsillectomy going very deep. But sometimes, you have to do it, and it depends on your. But in general, I agree with Shahrukh. If you don't cut too much muscle, even if you take the mucosa, they don't have that much of a problem.
Yeah. And they tolerate it okay. They do have pain. They stay in the hospital maybe overnight, and then we send them out, and then they just heal up. It is a painful process. They do need narcotics. So anyway, so this guy did undergo a neck dissection, and his pathology did not show any extranodal extension. So he wanted to have surgery done, and so he ended up, he had the option, we gave him the option of getting radiation therapy or observe, and basically he's now gone into the observation arm where we're just going to watch him. There was no extranodal extension.
Oh, wow.
Yeah, nothing. So here's a pathology report. Let me just put you guys out of the way. So he was offered primary radiation versus neck dissection, followed by adjuvant therapy, depending on what the final path will show. He opted for surgery. 1 out of 36 nodes positive. Squamous cell cancer, P16, no extranodal extension. But the lymph node was big. So I think I'll open it up to you guys with that size, single node, should this guy get radiation anyway. So I'll open it up to you guys, and Tamer's online, and Don's online, anyone else who wants to, because we did offer him radiation just based on that size, and he said forget about it.
Well, I think there's two important points of it. One is, do you do adjuvant therapy based on the nodal disease? And I guess technically speaking, since you assessed all the Waldeyer's ring and no primary tumor was found, this would be a T0 since we have P16 status. And so the big question then is also, even if you were doing radiation for the neck, would you treat the pharyngeal component? Because that's where a lot of the morbidity comes in. I would usually consider treatment adjuvant to the neck with that level of disease, but then the question is, do we just closely observe the pharynx?
Andrew or Bob?
Yeah, one comment about the size, as it pertains to HPV positive disease. I think a lot of the size, the 0 to 3, 3 to 6, was really developed in the area of HPV negative disease, where you had solid tumors, and a 3 versus a 6 was a much higher volume of disease. In HPV positive disease, it's just a rim of viable tumor at the edge of a very large cyst. So I think that the diameter probably has much less implication in terms of how aggressive that tumor actually is. So I would lean more towards, I think, observation, given that the volume of disease in that scan really looks quite small. I don't know if anybody's looked at that specifically, but it'd be an interesting thing to study.
So being from Memorial, I got a quote a Memorial paper. This is an old Memorial paper that we did a lot. Well, I wasn't there at that time, but I'm blanking on his name, the chair before Dr. Shah. So they basically looked at, way back when, before we know about HPV, they looked at unknown primary with neck dissection to see what happens. And the first series, they just did and back in the day, it was a radical neck dissection for everybody. And they did a radical neck dissection, and the recurrence rate was actually very low. A lot of people did quite well, which is exactly your case, basically.
Yeah.
And it was about, I would say, even, mixing HPV positive, negative, mixing all the other skin cancers, it was about 30% recurrence rate.
81 degrees.
What's that? And then the next paper, Elliott Strong recommended radiation. And he noticed that if you do a neck dissection plus radiation, the recurrence rate goes way back to now it's like 5-10%. And then he changed his practice, and he would do neck dissection plus radiation. Now, at the age of HPV, it's very different. I don't think it's completely nuts not to radiate. Always makes all of us very, very nervous. And so, every time Shahrukh sees this guy, thinks about, oh my God, why did I radiate this guy? But I think there should be some room. Personally, I think at this point, for advanced disease, which is considered advanced disease, so multimodality treatment is what most people would be more comfortable. So I would strongly recommend that he has adjuvant RT. And definitely with all those caveats that Arno and Shahrukh mentioned, that about not, giving high dose radiation to the constrictor and limited to unilateral neck. That's what I would recommend. But if he absolutely doesn't want radiation, it's not crazy.
Yeah. Now, how would you guys monitor him?
That's another session in itself.
Yeah. So that's something to think about. We do get post-treatment imaging about 3 months after the last treatment. So this guy would get a imaging study of some sort. Now, a lot of time we are held hostage by the insurance company and what they approve, whether they approve a PET scan or a CT scan or MRI. So we just go by whatever we can get, but he will get some kind of imaging. So that's
a great question. I personally would get a PET scan, PET CT in 3 months. And my recommendation, my reasoning with any insurance company, I call them and say, well, if this guy had chemo RT, you didn't even think about approving chemo PET scan. What's the difference? My treatment is also treatment.
Yeah,
it's the same thing. Why we are having that conversation? And most people would agree with that. The question is, would you repeat the imaging in a year or 6 months if the patient is asymptomatic?
So my paradigm is I'll get a scan in about 3 months. If that's fine, then we just follow him out with physical exam and then get an annual scan of some sort. So they'll get it on end of year, the anniversary of the treatment, and then they'll get it the second year, third year, and beyond. We see how the patient's doing.
Is anyone getting circulating tumor DNA on these patients?
I have not done it, but I think that was done in MD Anderson. I think
UNC. I know UNC does a fair amount. I think initially people were considering it for screening, but actually for surveillance is I think where it's teasing out to have a fair amount more significance. And I can actually follow up. I just was reading an article earlier today that has some preliminary data that's fairly impressive for its sensitivity and specificity. So basically they follow these, get a pre-treatment level, and then on regular intervals use it. And it's actually quite predictive as far as sensitivity of picking up. It's not perfectly specific at the present time, but it's especially if you get a couple consecutive ones, it's a pretty good test for surveillance.
Okay. We have a question from the audience. Would like to know how our other faculty do their approach to positive margins when you do a lingual tonsillectomy. Would you re-resect or recommend RT? I think a couple of us commented, but Arno and Mike and Don, whoever's on call on the line, can you comment? What would you do?
For a positive margin on a lingual tonsillectomy?
Correct.
So I typically excise, I do frozen sequential, so I'll ink my specimen and start with either the lingual tonsil or the palatine tonsil, whatever I think is highest risk. And I'll fully ink it and fully section it and do the frozens at the time. So it takes a lot of time, and the robot does sit there waiting while I'm between my specimen harvest. But typically it does allow me the opportunity to re-excise to a negative margin in the event that I do find the tumor at the time of the operation.
Yeah, this is Tamer. I would do the same. I mean, I normally do frozen sections if they find it. Now, I have cases where they have not found a tumor on frozen section, but found it on permanent section. And, where it's close to a margin that I can tell, and, like if it's laterally and I know kind of the area, then I can go back and re-resect and see if I have a negative margin or not. If I can't, then obviously reliably do that, then we'd offer radiation and chemotherapy for that.
Okay, so that's it. This is on top.
Thank you. That was an excellent case.
Thank you. So we're climbing this mountain, so everyone should take some time out. This is before COVID, obviously. We don't have social distancing down there. Those are my boys. So we go around hiking.
I thought this is your hideout for COVID because all the millionaires have run out of the town. I thought you're up there too. You're talking from there. Question for Mike. Would you please share that paper about the circulating tumor DNA?
I sure Will, yeah, I'll send it out to the group. And I do think those first and the last cases really highlight the differing presentation of the HPV negative and HPV positive disease. You know, one comes in with classic throat pain and or difficulty swallowing, typically a primary tumor is causing the presentation rather than a nodal disease. And then the other one's a classic shaving cancer. Somebody finds an asymptomatic neck mass just while feeling their neck or shaving. So really, those are the classic scenarios that you'll be faced with. You could almost predict the HPV status based on the clinical presentation on those.
Very true. Very true. I agree with that. Okay, it's 8:03, I think.
Oh, wow, we finished on time.
Yeah. Well,
Thank you guys so
all.
much for preparing those. Great cases.
Thank you for inviting.
Thank
you for all the guest faculty who commented, Tamer, Don, and others. We invite everybody to join us as discussants, as presenting cases. All the fellows are more than welcome to join. This is for you guys. I hope it's educational. Please feel free to reach to any of us. As you can see, you know, I'm not an expert, but Charuk and Mike and Arno are much busier surgeons than I am, and I'm sure we can find the answers for you. Let us know what would you like to see and what kind of cases, what kind of format. Give us feedback, what we can do better, what we can do differently. This is all new. This is our second session. And we really look forward to do something that's meaningful and educational for all of you guys. And again, thank you, Charuk. Thank you for doing this in short notice. And Mike, thanks for moderating the session, and Arno. And of course, JJ, who set the whole system up in basically 2 days.
JJ is a man.
I try.
All righty, guys.
All
Good
right.
night.
Thanks, everybody.
Thank you.
Thank you.
Thank you.
Thank you. Good night.